Our first speaker is Dr. Chawke, respiratory consultant at University Hospital, Kerry. Dr. Chawke's presentation is entitled Pulmonary Fibrosis. So with that, I'll hand over to you, Doctor, now. Thank you.
Sorry. You can all see that, okay, Justin, yeah?
Yep.
Okay, great. Good morning to you all, and thanks very much to ILFA for inviting me to speak this morning. My name is Chawke. I'm a newly appointed respiratory physician in University Hospital, Kerry, and along with my colleagues, it's my great pleasure today to chat about IPF for the morning. It's going to be a very basic talk, and please feel free to ask any questions through the chat box or to the Q&A box as you see fit. As I mentioned to the panelists before we came online, that my wife is working, so I have 3 kids downstairs who I'm hoping are behaving themselves and hopefully doing what you see in the top left-hand corner, but probably doing what you see in the bottom right-hand corner. But as long as I hear some background noise, I know that they're okay. And silence will be a warning sign. So just an overview of what IPF is in terms of its symptoms, its clinical presentation, its diagnosis, its management. And while I speak on IPF this morning, some of these principles apply to other non-IPF progressive fibrotic interstitial lung diseases, which I'll allude to briefly in some of my slides. So what is IPF? So essentially, to break it down, so idiopathic means we don't know the cause of it. Pulmonary relates to the lung itself, and then fibrosis is scarring of the lung. And if you look at the hand on the bottom right-hand corner of the screen, so we have an injury or cut to the hand. It starts off by becoming inflamed, and then it can heal by scarring. This is in the basic sense what happens in the lungs, maybe not so much an inflammatory component, but certainly the scarring process. So essentially, we have a disease that causes our lungs to become scarred, and therefore their function becomes less efficient. So the problem with IPF is that it can look very similar to other fibrotic lung diseases, and people with connective tissue disease like rheumatoid arthritis, scleroderma, or myositis. Some of these patients will ultimately develop an interstitial lung disease that can look a bit similar to idiopathic pulmonary fibrosis. And some other conditions like a hypersensitivity pneumonitis, where you inhale something into your lungs, it causes an inflammatory type reaction in your lungs, and you end up with some scarring of your lungs. And the most common of these would be farmer's lung or bird fancier's lung. So who gets idiopathic pulmonary fibrosis? So it's extremely rare under the age of 50 years of age. It's more common in adults of older age and slightly more common in men. It's more common in people who have smoked or previously smoked and worked in dusty or in industrial environments. And it's usually sporadic, but it does run in certain families where you get familial pulmonary fibrosis, but it's beyond the scope of this talk this morning. The numbers of people that we see getting IPF is increasing. And that's what the most important thing that we try and do in the clinic or in an inpatient setting is that we differentiate IPF from other forms of interstitial lung disease in terms of how we manage IPF going forward, because it's quite different to how we manage some of the other interstitial lung disease. So it requires exclusion of other forms of interstitial lung disease associated with environmental exposure, such as farmer's lung or bird fancier's lung or hot tub lung or mushroom lung, medications that might affect our lungs, and other systemic diseases that I've alluded to in the previous slide, like rheumatoid arthritis and scleroderma. So when we see someone in a GP setting or in an respiratory outpatient clinic or an inpatient in a hospital, I suppose IPF we should always consider in someone that's over 50 plus they've been breathless for a period of time, usually months to 1 or 2 years. They can complain of a dry cough that doesn't have any particular pattern to it. They're just coughing throughout the day. It's usually dry. When you listen to their chest with a stethoscope, you can hear these Velcro crackles, and it's like you're rustling your hair between your fingers. That noise that it makes, that's the type of noise that we hear on auscultation of the chest. And then depending on how advanced they present, we can get this phenomenon called finger clubbing, which is changes in the shapes of the nails of the hand and the feet. I'm just going to see if it works in terms of trying to play my slide here as in terms of the audio as to what we can hear when we listen to someone's chest. Hopefully it works. And I don't think it is. Anyway, essentially, if you rustle your fingers, your hair between your fingers is essentially the sound that we hear when we listen to someone's chest. In terms of risk factors or genetic factors, so cigarette smoking is probably the biggest risk factor for someone with IPF. environmental exposures, so metal dust, brass, lead, steel. So in terms of your occupation, we normally go through it in detail when you come to the clinic. In terms of your other backgrounds or other exposures. Farmers, we go to their background in terms of what they've been hailing on throughout their daily work in terms of mouldy hay, any dust from nuts they're feeding cattle, etc. Someone that might keep pigeons or budgies or work with them, keep them as pets, etc., and can develop bird fanciers lung, and then stone cutting, again, inhaling a particular dust. Currently, there's no genetic risk factors associated with sporadic IPF that we know of, but in terms of familial pulmonary fibrosis, there are, but again, beyond the scope of this talk this morning. So in terms of the investigations that we do, I say in the outpatient setting, but equally if there were an inpatient and they had an abnormal chest X-ray that prompted us to investigate them for a type of interstitial lung disease. So bloods we normally check both their inflammatory markers, autoimmune bloods to exclude or include rheumatoid arthritis or scleroderma, or myositis. We can also check various antibodies to determine if someone has risk of farmer's lung or bird fancier's lung. The pulmonary function test allows us to assess someone's lung function with their basic lung function when we first meet them, and then following sequentially throughout their lifetime when they come to our clinic. And some of you may have had it done, some of you may be waiting to have it done, and it's not easy to do it. But it's a part of the basic workup that we do to determine the severity of someone's interstitial lung disease. Usually the first port of x-rays in terms of imaging that we do is that everyone will have a chest x-ray done initially that kind of, I suppose, heightens our suspicion that there's some fibrotic looking changes on an x-ray, but it's a 2D representation of a 3D structure. So we always progress on to having a CT scan of your chest. Again, not easy to do when you have to lie down and hold your breath in someone that's particularly breathless. So we do appreciate that, but it gives us a huge amount of information in terms of the anatomy of someone's chest with potential idiopathic pulmonary fibrosis. I suppose another test I suppose a staging test or something we do in the outpatient clinic when someone's chronically well is a 6-minute walking test in terms of the distance that they walk, what their oxygen levels are at the start and every minute throughout the test, and how breathless they feel, and whether someone needs. So we use it, I suppose, in terms of monitoring someone's progress, monitoring someone's response to treatment, or whether they need oxygen full time, or whether they need it only when they exercise. But these are kind of the basic tests that we do when someone comes to the outpatient clinic. So in terms of idiopathic pulmonary fibrosis, it's an exclusion of all the other causes of ILD. So when you come to the outpatient clinic or in an inpatient setting, we go through a thorough history in terms of any exposures, any drugs that you might be on that cause interstitial lung disease, any features of a connective tissue disease, any family history of pulmonary fibrosis. We send off the various bloods that I've mentioned in the previous slide or two. And then I suppose our diagnosis is based on the presence of all the hallmark features on your CT scan of idiopathic pulmonary fibrosis, where we've excluded other causes, and therefore no lung biopsy is required. If the CT has some of the hallmarks of idiopathic pulmonary fibrosis, we may need to proceed on to having a lung biopsy performed, which can be done in a couple of different ways. I suppose international best practice, and you might have heard some of your consultants telling you this, is that we need to discuss your case at an MDT. So at that stage, we will have collated all your information in terms of your history, what we find in examination, all your blood work that you've had done, any imaging in terms of chest x-rays and CT scans that you've had done. And we discuss each patient at our multidisciplinary team meeting, which should consist of at least 2 respiratory physicians, a radiologist with a special interest in chest pathology or chest interstitial lung disease, and again, pathologists in terms of reporting lung biopsies, and again, with a special interest in interstitial lung disease. And at the end of each of these MDT, we have a diagnosis and a plan for each of our patients. This is just a slice, and they're not the same patient, and they're not at the same level, but just to demonstrate the image on the left is what a normal lung would look like. So on the right is your right lung, this black structure here, and on the left is the left lung here. This circle, can you see my arrow, Justin, actually? Yeah, we can, yeah, Brent. So this is the main windpipe, your trachea. This slit-like structure here is your esophagus, and this is probably the main blood vessel in the body, the aorta. And on the right, you can see lungs with idiopathic pulmonary fibrosis, where you see all these little holes or cysts here. This is called honeycombing. If you can imagine a beehive or a honeycomb stack with all these little holes stacked on top of one another. And usually when the lung starts to fibrose, the lung starts to shrink down, so you lose volume in your lungs. I don't know if you can appreciate this little structure here from my arrow is, but this is an airway within the chest. And normally we don't see airways out this far. So we normally see them close to the center, close to the heart, close in terms of this area here. But as the lung starts to fibrose and it starts to harden, it starts to pull airways apart. And you can see them again a bit closer then to the periphery of the lung here. So these are the kind of features that we look at when we're suspecting someone with interstitial lung disease or idiopathic pulmonary fibrosis. Excuse me. So the key principles of management in terms of is, I suppose, number one, maintaining physical fitness, and that we use oxygen when needed, and pulmonary rehabilitation programs. The pulmonary rehabilitation programs at present are usually in the hospital, but with the integrated chronic disease respiratory care program, a lot of pulmonary rehabilitation for COPD and other chronic respiratory diseases are now being moved to the community. Some of you may still be doing them in the hospital, some may be doing them online in conjunction with the hospital, with ILFA, with Eimear. But the majority of these will ultimately move to the community. Just in terms of Kerry, there's a very much an integrated physiotherapy department in that the physiotherapists go to the community, not necessarily a respiratory hub as part of the integrated program, but in terms of if they get a couple of referrals for pulmonary rehab to fill a class in Carita, the physios go to the patients as opposed to the patients coming to the physio department or to the hub where the respiratory care program will be run from. It's important to maintain general health, and I suppose a lot of people with idiopathic pulmonary fibrosis will have other comorbidities like hypertension, may have coexisting COPD, may have obstructing sleep apnea. So it's a case of, I suppose, optimizing the management of those treatments as well as for interstitial or for idiopathic pulmonary fibrosis. Avoiding infections like COVID and influenza and respiratory syncytial virus, which is rampant at the moment. Preserving lung volume, and then always keeping in mind, I suppose, quality of life and symptom management. In terms of our symptom management, excuse me, we often, I suppose, enlist the care of our palliative care colleagues. So their role has expanded in the last number of years to dealing with symptoms and refractory symptoms that we sometimes as respiratory physicians have difficulty controlling. I suppose the two biggest ones would be cough and dyspnea. And I suppose it's now more in vogue that we have interstitial lung disease and palliative care MDTs to discuss patients and how we can best manage their symptoms and improve their quality of life. I took this slide from the American Thoracic Society document. It's one of the guidelines that we use for investigation management, diagnosis and management of interstitial lung disease, but I think it encapsulates a lot of what I've spoken about this morning. So starting from the left, your diagnosis of IPF, treatment considerations in terms of pharmacological therapy, in terms of nintedanib and pirfenidone, which I'll speak about in a second. Non-pharmacological management in terms of oxygen supplementation. So we may see someone in clinic or in the hospital and we suspect, they're desaturating or their oxygen levels become a bit low. And as an outpatient, we refer them for a 6-minute walk test and an arterial blood gas to our oxygen assessment clinic. And I suppose there's 3 outcomes there. 1, they don't need any oxygen. 2, they need oxygen or ambulatory oxygen when they're exercising. Or 3, they need it full time. It's really important that we never forget about pulmonary rehabilitation in terms of any patient with a chronic respiratory disease, that they have access to a pulmonary rehabilitation class. We also have to think about comorbidities. So in terms of pulmonary hypertension, so we can measure systemic blood pressure when we put a blood pressure cuff on someone's arm, we measure the blood pressure in the body, but there's also a blood pressure circuit between the heart and lungs. As blood goes from the heart to the lungs and the lungs back to the heart, that can increase. In someone with a chronic respiratory disease that's chronically hypoxic and that their oxygen levels are chronically low, that blood pressure circuit increases and it makes someone more breathless. And in basic terms, the treatment for that is prescribing oxygen appropriately. Gastroesophageal reflux is important to recognize in someone with IPF and to treat appropriately. Obstructive sleep apnea, again, important. And there's a slight increase in risk in someone with IPF for lung cancer, but we will be seeing you in clinic at least every 3 to 6 months. And these are the kind of questions we will be asking in terms of trying to tease out the presence of and management of these comorbidities. And again, important in terms of symptom control, that if it gets to the stage where someone's quality of life is being affected by breathlessness and cough, and we as respiratory physicians feel we need to collaborate with other medical healthcare professionals, we often ask our palliative care colleagues to see these people, our patients, sorry. In terms of if someone continues to progress, whether they're on antifibrotics or not, that we always have at the back of our mind lung transplantation, which is done at the National Heart and Lung Transplant Unit in the Martyr in Dublin. And this is always at the back of our mind and when to refer people appropriately. So in the clinic, we monitor for disease progression with the pulmonary function test every 3, 4 to 6 months with a 6-minute walk test, repeating your CT scan. So HRCT that you see there is high resolution CT scan. It's a dedicated fine detail scan looking at the anatomy of your chest. If you think that someone's acutely exacerbating in that, what we mean by that is that you become more breathless and your cough becomes a bit worse over a short period of time in terms of days to a few weeks. And there's always, I suppose, a slight increased risk of pulmonary embolism. And if we do consider that, then a different type of CT scan is required. The treatment for an acute exacerbation, usually these patients need to come to hospital for those high-dose corticosteroid therapy. The evidence is weak, but it's some evidence that we do have. And then that we're monitoring for someone that may or may need oxygen, and again, referred to palliative care and our transplant colleagues as appropriate. Again, Eimear will speak about this, but pulmonary rehabilitation is the single biggest thing that you can do for yourself in terms of making you feel better physically and psychologically. You can participate in the class without oxygen when you need exercise, or if you're on it full time. And as I mentioned, pulmonary rehab is now becoming a community-based program that hopefully everyone should have access to. Lindsay will speak about these, but just to briefly introduce them, there are only 2 FDA-approved treatments for IPF at the moment. OFEV or nintedanib, which is 150 milligrams at full dose twice a day, or esbriet-pirfenidone, which is 3 tabs 3 times a day, or now has a full dose 1 tab 3 times a day. So the purpose or the aim of these medications is to slow the rate of decline, and how they do that varies from person to person. And it's not their rate of decline is not predictable in any way. There are some side effects associated with them. Briefly, with esbriet, it's photosensitive, and that if you're exposed to too much sun, you can get a photosensitive rash. It can affect your liver function test. You may feel nauseous on it. In terms of nintedanib, it can affect your liver function test, and again, can make you feel nauseous with some diarrhea. But I suppose what's important here is that if you are on them and you've newly started on them, that in terms of managing the side effects, that you liaise with us or teams, respiratory clinical nurse specialists, respiratory advanced nurse practitioners in terms of how to best manage these. And sometimes we won't stop them. We will dose reduce and tell you to take less of a dose for a period of time and then to up titrate as your symptoms in terms of side effects become under control. But there are a certain proportion of patients that can tolerate oral antifibrotics, and I suppose there's no guidance that in terms of whether we should start one on nintedanib or pirfenidone or vice versa. Sometimes we start them on one, they can't tolerate, we switch them to another, and in some cases, patients can't tolerate either. COVID has been challenging. It's a highly infectious virus, and it's a bit more cumbersome in those with chronic respiratory disease. We've been limited in our capacity to see patients in clinic and for pulmonary rehab classes. But we're slowly getting back to inpatient pulmonary rehab or in-person pulmonary rehab classes. It has been challenging in terms of pulmonary function testing, in that we haven't been able to do as many per day as we would like because it's an aerosol generating procedure, but we are getting back to pre-COVID, somewhat pre-COVID levels. So IPF, it's an extremely complex disease with many drivers. However, we do lack some good understanding of the individual patient differences and why some patients progress at the rate they do, why some patients don't respond well to the antifibrotics, why some progress faster than others, why some don't tolerate some of the antifibrotics, why some tolerate one over the other. So we lack some understanding in terms of that, but there's ongoing research to try and address each of these issues. The research is important in terms of this trial. I'm not going to bamboozle you with information, but it was a trial that was done nearly 10, 12 years ago at this stage, looking at corticosteroids, an immunosuppressant drug, and a drug to try and help suppress cough. And was found to be deleterious in patients with IPF, and it was terminated quickly due to the increased morbidity and mortality with it. So it is important that we do clinical trials and that the medications that we are giving people have a benefit. I just put a link here at the bottom of the screen, but it's essentially www.clinicaltrials.gov, and into it you can put in the condition idiopathic pulmonary fibrosis, and you can select the country, Ireland, and it will tell you about all the clinical trials that are starting, that are currently recruiting, that have completed in idiopathic pulmonary fibrosis, and also nationwide. A lot of these clinical trials that are done will have a centre or two in Ireland. A lot of these international trials, that are being done will have a centre somewhere in an interstitial lung disease clinic in Ireland. And so it's worth checking them out, or asking your respiratory physician if they're aware of any clinical trials that are ongoing at present, and if they're eligible to be enrolled if it's indicated. So just to summarize, it's a progressive lung disease that's becoming more common. and we always need to think about if someone is progressing despite appropriate treatment with oral antifibrotics, that we consider referral to the transplant centre. Exercise and maintaining general health, along with the oral antifibrotics, if appropriate. Managing comorbidities such as pulmonary hypertension, gastroesophageal reflux disease, obstructive sleep apnea, are all really important in terms of managing someone's overall health. And clinical trials and translational research are important in terms of developing new personalized treatment for patients once we gain better understanding of the treatments of IPF. And that's all I have to say. Thank you.
Well done, Liam, and no disturbances from your kids downstairs. I'm just going to get you to start your video there again. I have a couple of questions in here for you. Question for Liam: what's the best advice in the current climate of what to do when you have an acute extubation? Is it A&E or GP?
I suppose, unfortunately, in most hospitals, the only way to get into the hospital is through the emergency department. It's not the best way to do it, but normally, I suppose, if someone has an exacerbation, they will need high-dose steroids. Some may need antibiotics, even though it's not evidence proven. Some will need to exclude any other potential causes of their breathlessness. So ultimately, it will be pick up the phone to phone their respiratory physician or respiratory clinical nurse specialist, advanced nurse practitioner, or someone on the interstitial lung disease team to alert them to what they're experiencing. But they'll ultimately end up, I suspect, in the hospital to optimize their symptoms.
And on oxygen recently, and information seems to be limited, who can advise around the use of oxygen for first timers?
So usually, I suppose, if I was prescribing someone oxygen, I would give them the information for it in terms of a leaflet, and it's very much hospital dependent, but there is a guideline on the Irish Thoracic Society website published about 5-6 years ago. I'll have to double check when it was published, but there is a guideline on the use of oxygen for someone with IPF, with interstitial lung disease.
Okay, we get two more questions here. Is talcum powder considered irritant?
Not that I'm aware of, but I will check it out. But I suppose if it is an irritant and someone starts coughing when they take it, I suppose it's something that should be avoided. But I will check it out in terms of as a cause or an environmental or an inhalation exposure for triggering IPF in a genetically susceptible individual.
And last question for the moment. And of course, if you have questions throughout the webinar, you can stick them in the Q&A box, and all our panelists have the ability to answer them and write to them. What do you do to preserve lung volume? I think that's going to be a question that's going to be coming up later on when we talk about exercises. But
yeah, so I suppose that we identify and diagnose early, that we get someone on antifibrotic treatment, I suppose, as quick as we can, and pulmonary rehabilitation. So it's one thing that will reduce your lung function, and that's been evidence-based, is an acute exacerbation. So it's a case of trying to reduce or eliminate your risk of acute exacerbation. So they're kind of the basics that we can do in terms of preserving someone's lung function.
Great, thanks for that, Liam. I'm going to move on because we're conscious of time, and I'm going to ask Eddie to introduce the next panelist. I'll get you to unmute there, Eddie. Thanks for that, Liam.
No problem, thank you.
Thank you, Dr. Liam. Most informative, really, really very interesting. Thanks again. Our second speaker is Lindsay Browne, Advanced Respiratory Nurse Practitioner at St. Vincent's University Hospital, Dublin. Lindsay's presentation is entitled Managing Medication. With that, I'll hand over to you, Lindsay.
Thanks to ILFA and to everyone for the opportunity to talk to you today. I've been asked to talk to you about medication management, and I'm going to talk to you about that in terms of the principles of medication management and its impact on patient safety, but also talk about the two antifibrotic drugs latterly. So medication management is a vast and complex issue, and it covers a number of tasks. Now, I'm not going to touch on all of these today, but again, the focus will be on patient safety. So why is that important? So medicines prevent, treat or manage many illnesses or conditions, and are the most common intervention in healthcare. According to the World Health Organization, between 30 to 50% of medicines prescribed are not taken as intended, impacted upon by the number of people with long-term conditions necessitating the use of several medicines. And 49% of the Irish people over 50 years of age have at least one long-term health condition, and 65% of adults over 65 have two or more long-term health conditions. So what is a long-term health condition? It's a condition that cannot at present be cured, but is controlled by medication and or other treatment or therapies. And we talk about multimorbidities, which exist if you've got two or more long-term medical conditions simultaneously. And these are strongly associated with physical and functional decline, decreased quality of life, and increased healthcare usage and costs. A study by Trinity in 2021 found that in an Irish population, morbidity or multimorbidity was at 38.6%, which internationally is relatively low in comparison to America, where it's 60.7%. And this study also noted that we have a world population both aging and expanding rapidly, and patients with multimorbidity are becoming the norm and have complex medical needs that pose challenges to healthcare capacity and cost. So we talk about prescription medications and polypharmacy, and a study by the HSC in 2020 found that 44% of the population interviewed were on prescription medications in the previous 2 weeks. This increased to 87% in the 75 plus age group, with 32% also reporting the use of non-prescription medicines in the previous 2 weeks. So we talk about polypharmacy, and in adults in the over 50, Tilda also did a study in 2012, which showed that 69% were taking regular medications, and about 20% of the over 50s were taking more than 5 medications. So we just look at hospitalisation. 11% reported being admitted to hospital as an inpatient on average 1 time per year. And in the 75 plus age group, 21 to 24% of people were admitted to hospital on average over 3 times a year. And actually 8% of all emergency department admissions were drug related, according to Sheahan in 2013. So we talk about appropriate polypharmacy. So what does that mean? It means that prescribing for an individual for complex conditions or for multiple conditions in circumstances where those medicines use has been optimized and where the medicines are prescribed according to best evidence. And that means medicines being optimized. So in order to do so, we require a person-centered approach to the safe and effective medicine use to ensure that people are getting the best possible outcomes from their medicines effectively. But that needs to take into account that individual's needs, preferences and values, and involve them in shared decision-making about the treatments that they're willing to accept and the care provided to them, with obviously the overriding principle being to minimise harm. But nevertheless, errors do occur. And joking apart, drug incidents or near misses are taken very seriously and are subject to reporting, analysis and quality improvement initiatives. We also have to be mindful of allergies and anaphylaxis. So essentially, if you develop a rash or an itch, or you get swelling of your tongue or your lips, you are clearly allergic to those drugs and you should never take them again. But the important aspect of this is know clearly what that drug was, so that you can in future inform health professionals that there's never a risk that you receive it again. Further sources of error include things that we call salads. That means sound alike, look alike drugs. And that could be because the packaging looks similar, the medications are similar colour, or the word sounds quite similar. So, for example, bisoprolol is a laxative and bisoprolol is used for high blood pressure, and you wouldn't want to be mixing these up. Similarly, people talk about proprietary drugs versus generic drugs. So proprietary drugs are the initial drug onto the market, and millions have been invested in the research and development of these drugs. So the drug companies are given a patent for circa 20 years, because it can take them 12 years in the development to get the drug to the market, and they need to recoup monies in order to reinvest in further research and development. Generic drugs, on the other hand, when the patent runs out, any drug company can make the same medication without undertaking research and development, but they're essentially the same drugs, but the generics are cheaper. And then, of course, if people are taking OTC meds, that's over-the-counter medications, then you don't need a prescription for those, but there's still the potential that they can cause harm in terms of perhaps drug-to-drug interactions. The other issues where the errors can arise is in the administration of a drug. So you might take the incorrect drug, the wrong dose at the wrong time. You might take it at the incorrect sequences via the wrong routes. You might take it for too long or for too little. You might forget to take a drug on occasion, and you might try to play catch up, which can have implications for side effects. Dietary issues can arise in terms of administration of medication. Some need to be taken with food, some without food, just with a glass of water, and some drugs are affected by grapefruit juice because it interferes with the pathway along which they are designed to work. Similarly, if people have multiple presentations to hospital or their GP, there can be lots of changes to their medications. And it's very important that you know what the changes are, what your new medication is. Have you had to stop another drug as a result, or have you got to put a drug on hold temporarily? And adverse events can occur, and they can be reported to the Health Products Regulatory Authority. So drug-to-drug interactions can also occur. And one of the drugs that very commonly this can happen with is an antibiotic, and some of you may have already received this, and that's called clarithromycin or classes. So sometimes if someone is to be commenced on that antibiotic and there isn't another suitable alternative, they may have to hold other drugs that they're on, such as a statin that might be used for cholesterol levels, or say colchicine for gout because it increases toxicity. So the key issue is there's a danger that there's lack of information. So it's important that you get information from the prescriber or the specialist nursing team regarding medication that you are being prescribed, because to be forewarned is to be forearmed. And also, for every medication, there is a summary of product characteristics or indeed a patient information leaflet within the package that you can refer to. And if you have any concerns, you can contact your healthcare professional for further advice. So this brings us on to the question of how drugs are processed in the body, and that's called pharmacokinetics. And pharmacokinetics begins with the drug being liberated. So when you ingest a capsule, the capsule breaks down, and then the contents are absorbed into the body by the guts and go into either the bloodstream or the lymphatics, and then are distributed around the body via carrying agents or transporters, and they are generally metabolized by the liver and broken into the active agent and also waste products, which are subsequently excreted by the body, either in the bowel or generally by the kidneys. But this process can have factors impacting upon it, and this is just an indication of some of those. So with aging, we can have reduced liver, kidney, gastrointestinal function, which will impact on the processes of pharmacokinetics. We can have reduced body fluids, and also reduced memory, dexterity, and some sensory difficulties that can impact. And also, if you've got increased body fat, so for example, if you're morbidly obese, you might need to require dose adjustment and further monitoring of medications. And the operating pharmacists use a formula in order to work out what the appropriate dosing would be. So how do we reduce risks? So we require robust systems to report, identify, and learn from medicines related patient safety incidents. I've mentioned the HPRA, but every profession has a professional body, so the NMBI for nurses, the IMC for medical staff, and the PSI for pharmacists. But similarly, the government issue guidelines that institutions have to follow in relation to patient safety, and each institution will have its own policy based upon these guidelines. But key to this process is communication systems between care settings. So if a patient gets admitted, they could get transferred to another setting, and a letter accompanies them that indicates their medication. You get discharge prescription, letters get transferred from hospital to GPs, and similarly when you attend your outpatient department, your GP will get a letter. And if you come into a hospital, there is a process called pharmacy reconciliation, where if you're uncertain about what drugs you're on, your pharmacist will contact the GP or your local pharmacy to establish exactly that. But it's extremely helpful if each individual has a medication list. And an example of such would include the drug name, the dose, the frequency of use, the reason why you're taking it, how long you've been on the drug or how long you have to be on the drug, and who the prescriber is, in order that if any issues arise, you can go back to that individual to report it and get guidance. So the other means of reducing the risk is to ensure that that medication list is constantly updated when new things are started, stopped, dosage is changed, or the reasons for it. And it's important at the early juncture with any new medication that you report the side effects early and that you're aware of the red flag, as we would call them. So that's the danger sign that warrant early review. Share your drug information with your family and your carers, and know what the monitoring of that medication involves and when it should be reviewed, know when your follow-up appointment is, and have contact details to hand of your perhaps your specialist nurse that you attend in the clinic. So I'm going to move on and talk about each of the antifibrotic agents. So nintedanib, we know is an antifibrotic therapy. It comes in capsule form. It's a tyrosine kinase inhibitor, and it targets these growth factor receptor sites, blocking the pathway involved in fibrosis or scar development. It's administered twice daily, approximately 12 hours apart. It should be taken with or after food and swallowed whole with a full glass of water, and it comes in 2 doses. The initial dosing is 150 milligrams, but should someone be unable to tolerate that, we can reduce the dose to 100 milligrams if it's available on a high-tech prescription. So what do we know about it? Well, it's called OFEF or Vargatef. It slows disease progression by reducing decline in lung function, reduces acute exacerbation risk, helps to maintain health-related quality of life, and it's subsequently been licensed for use in chronic fibrosing interstitial lung disease, which have a progressive phenotype, including rheumatoid arthritis, progressive pulmonary fibrosis, and scleroderma, or progressive pulmonary fibrosis. When you start nintedanib, your doctor will ask you the following before prescribing it. So if you've had it before, have you had any sensitivity reactions? Do you have any other liver disease? Have you got any alcohol issues or drug use? Have you had heart disease or a previous heart attack in the last 6 months? Do you have a history of bleeding issues, so blood clots, having had a bleed, or are you on anticoagulant therapy? Are you planning any elective surgery? Do you have a peanut or soy allergy? And again, it's never prescribed in pregnancy or breastfeeding because we don't know the risks. There are special instructions with this drug, so we said it should be taken twice daily, 12 hours apart. If you miss a dose by more than an hour, you should not try to play catch up. You should resume your treatment at your next scheduled time and at the recommended dose. You should never exceed the 300 milligram dose in a day. And if you're having side effects, it may be possible for us to give you what we call a drug holiday. So we would temporarily interrupt treatment and perhaps get your liver function rechecked. And then if that normalizes, we may consider reintroduction at a lower dose. And then there's dietary advice, which I'll come back to in a subsequent slides. This drug potentially can have interactions, and there are either P-glycoprotein inhibitors or P-glycoprotein inducers. The inhibitors will increase exposure to nintedanib, and the inducers can decrease exposure to nintedanib. So they affect basically your blood levels. And then in terms of adverse effects, so diarrhea would be the kind of major concern with nintedanib. But in the study, the impulsive studies 1 and 2, they actually found that only 3.3% of people developed diarrhea to a severe intensity. The majority of people would experience it either not at all or to a mild degree. The dangers therein would be dehydration, stomach cramping, and sore skin around the perianal area. So the way in which you manage this is that you avoid laxatives and high fibre foods. You should always carry anti-diarrheal medication with you. That's called loperamide. You should start that treatment early with a loading dose of 4 milligrams, and at each subsequent episode of diarrhea, take 2 milligrams, up to a maximum of 16 milligrams in a day. You need to drink plenty of fluids, so keep water and drink it sipping over the course of the day to prevent dehydration. Avoid gaseous drinks. Eat small amounts much more frequently. Avoid coffee because it can increase gut motility, so the speed of your gut. Avoid alcohol, sweet, spicy, greasy, fried foods, and maybe go for low-fat options. Make sure you maintain your hygiene around the perianal area, and you can use barrier creams such as Sheahan. And if you're experiencing diarrhea excessively, obviously inform your IPF specialist immediately so they can make a call on the action to be taken. Now, the drug is metabolized by the liver, and so we need to ensure the liver doesn't get put under strain, and that is, we need to make sure that you don't become jaundiced, get abdominal pain, get nausea, vomiting, have dark urine, or feel exceptionally more tired than usual. So anybody that gets commenced on this drug gets baseline liver function tests done to make sure that there's no derangement before you start the medicine. And then you get your liver function checked every month for the first 3 months, and then 3 monthly thereafter. If your liver function is deranged at any point, the drug will generally, depending how much it's deranged, the drug will either be reduced in dose, or it may be stopped temporarily, liver function will be rechecked, and then you may be able to continue with the drug. But if your liver function remains 8 times greater than the normal upper limit, the drug will be discontinued, unfortunately. And then, of course, there is the potential that it can cause nausea and vomiting. And so you can take anti-sickness medication for this. But again, watch the foods you're eating, so not spicy, fatty, acidic foods or very heavy meals. Avoid strong odours, but try to make sure you're taking foods that are high in protein and caloric intake. Wear loose clothing. You might use fan therapy to help with the nausea and vomiting. Cold foods can help, and try relaxation techniques, and again inform your IPF team. So that moves us on to the final antifibrotic drug, which is called pirfenidone or Esbriet. And not as much is known about its cause of action. So it comes in capsule form, or rather tablet form now, and it kind of reduces the production of scar tissue or fibers, and it's thought to regulate TGF and TNF-alpha mediated pathways. Now, the dose with this has to be titrated upwards over a course of 3 weeks. So you start on a 267 milligram tablet 2 times a day. Week 2, you go up to 267 milligram tablets 3 times a day, and in week 3 and thereafter, should you tolerate it, you would remain on 801 milligram tablets 3 times a day. If you don't tolerate that, you may be able to get some benefit from staying on the lower dose of 2-3 times a day. And it's approved in Europe for use in mild to moderate IPF, and that's since 2011. Now, pirfenidone has the dangers of weight loss. And so it's important you weigh yourself before starting this medication and then on a weekly basis, because we don't want you losing excessive amounts of weight, because that can impact on your muscle strength. Again, liver functioning testing is required, and that's every month for the 6 months, and then 3 monthly thereafter. Again, you should report any side effects you experience to your respiratory nurse or physician, or who can guide you on any action necessary. It also has the potential side effect of hypersensitivity to sunlight, so it's important you protect your skin by wearing factor 50, even in dull days in Ireland, and you wear hats and long sleeves when you're out in the sunlight, and if you wash your hands, you renew the factor 50 after doing so. Other special instructions is that there are certain medications that can increase the side effect of this drug, and therefore alternatives may be required if you need to be commenced on them. And further special instructions are you should be taking food and water during or after a meal. Swallow the tablets whole, don't chew them. Again, avoid grapefruit juice. And if you need a drug called a proton pump inhibitor, which reduces acid production in the stomach because you suffer from reflux, then you can't be on omeprazole, and an alternative can be found. And rifampicin, a type of antibiotic, also you can't have this if you're on pirfenidone. Okay. So the same actions can be taken regarding nausea, as I mentioned previously. I've mentioned about the actions to take in terms of sensitivity to sunlight, but I would just say that avoid gas-producing foodstuffs that can cause bloating. Similarly, it can increase reflux, but also it interferes with the movement of your diaphragm and can affect the depth of breath that you can actually inhale. I'll move on from that. So what we know about pirfenidone is that it reduced decline in 6-minute walk test distance. It reduced disease progression as reflected by lung function, exercise tolerance, and progression-free survival in patients with IPF. It's associated with fewer deaths, and overall it's a safe drug with acceptable side effect profile. So, and finally, my take-home message in relation to medication management is I would suggest that you use a dedicated pharmacy for all your prescriptions, because your pharmacist is a gatekeeper and their vigilance can prevent the potential for drug-to-drug interactions or for you being doubled up in therapies unnecessarily. I would suggest you create a medication list and you update any changes on that at regular intervals, that you read the patient information leaflets that come with medicines, that you keep the medication in its original prescription pocket, or you get your pharmacist to give you a dose box so you know what time you take your medications at, that you know the benefits of medication versus the risks, that you ask about potential drug-to-drug interaction risks, that you follow the administration instructions to the letter, that you don't attempt to play catch up when that is if you omit a dose, that you attend for your blood test to monitor drug tolerance, and that you inform healthcare professionals of any side effects you experience, no matter how small they may seem, and any elective surgery that's planned going forward, you might require the medication, particularly nintedanib, to be held. And make sure you know who to contact for guidance. And finally, know the red flags that warrant an urgent hospital visit. Thank you very much for your time.
Thank you for that, Lindsay. I think Liam has been very busy on the Q&A box, and he's been answering a lot of the questions that have been coming in. So I think you're sort of off the hook. Let me just make sure that there's nothing. No, there's nothing actually else there. Liam was answering some questions on the different types of drugs as well there. I'm conscious of time, so thanks for that, Lindsay. I'm going to hand over to Eddie to introduce the next speaker.
Thanks, Justin. Our third speaker this morning is Eimear Bell. Eimear is a respiratory physiotherapist whom some of you may know from the weekly ILFA online exercise classes. Eimear's presentation is called Benefit of Exercise. So I'll leave it with you, Eimear, now. Thank you.
Okay, so what I'm going to be talking about first is I'm just going to talk a bit briefly about just what is exercise. So we often kind of use this word and sometimes maybe we don't really know what we're really talking about. Then exercise as part of our overall our wellness. And then I'm going to look at the benefits in detail. So kind of like different systems of our body, how it can improve the functioning. Then I'll have a look, or we'll talk about just in relation to lung fibrosis specifically. And then I'll mention also just some of the scientific evidence that is available at the moment, and then how we can achieve this exercise or physical activity, and then a little bit about how much that we should do. Okay, and also I'll be available for questions as well. So what is exercise and lifestyle physical activity? So often we'll mention or talk about exercising, and then sometimes people will wonder, but what about maybe the activities I do during the day and whether these are also part of it, and they are. So I'm just going to kind of go through some of these like definitions. So lifestyle physical activity is termed or defined as your daily accumulation of at least 30 minutes of activity. And this can be planned or unplanned leisure. So occupational, so that could be to do with your work or maybe like house tasks and gardening, for example, as well. But to be at least moderate in intensity, so that you would feel that your heart and your breathing rate will be coming up a little bit, but that you will be quite comfortable. Then the use or the word exercise then is normally when we're talking about a physical activity that is performed repeatedly over an extended period of time. So kind of like a specific time period, so 10, 20 minutes, 30 minutes. And normally you have a specific objective. So it could be like to do with a sport, to improve in a sport, or to do with your just fitness, your health, and trying to improve like different aspects of your physical body or your mental well-being. Then physical activity, like you'll see in the definition, that really it's any movement produced by skeletal muscle, so by our body, so a contraction of these muscles that results in a substantial increase in energy expenditure over resting level. So I suppose it's a fancy way of saying that you're kind of basically working different parts of your body, which means that your heart will have to work a little bit more, and also kind of like your lungs. And then this basically is that you're using more energy, which is good for you. So physical activity really encompasses both of the other two things. Okay. So the topics then, yeah, so that's what we just talked about then, exercise. Oh, sorry, I'm going the wrong way. Okay, so yeah, then often again, we talk about exercise and how it's good for us, but sometimes I think you can hear this and we maybe kind of switch off a little bit, the same as like if you're told to eat well and so on. But I think if you have a good understanding really of how really important it is for you, it can really help like your engagement and kind of really deciding to have it as part of your life. So a way it has been described, and I see it, is that it's a key component to your overall well-being. Okay, so it's one of these keys for you to kind of function as best possible at any given time. So other components will be good food, so like good nutrition, hydration, adequate sleep, and safe and comfortable environment. So this will be your home or even where you're working, healthy and caring relationships, sense of well-being, and then what I'm kind of talking about, physical activity. Okay. So yeah, so just again, to emphasize this again, one of the keys to for maintaining or being part of like your overall wellness. So if you can see it as us as a person, that we are like the physical body, which we'll be talking about a bit more later, but also our mind, thoughts and emotions, and then our sense of self. So exercise can help improve our physical body, but also our mind, so kind of like our mood, and then our sense of self, and then these in turn will interact with each other. So the whole idea is kind of being as well as you can be at any given time. So when I say at any given time, this would depend on if you have a medical condition like lung fibrosis, or even if there's other like medical conditions as well. So you're trying to work with yourself as you can. So now I'm going to look at some of the benefits more in detail. So like looking at different parts of our body, but remembering again that these can interplay with each other. So an improvement in one can help another body system as well. Okay. So the first one I mentioned then is fitness. So this is like basically an improvement in the kind of functioning of your heart and lungs together, so that your heart is kind of performing and working as efficiently as possible. And then muscle strength. So getting your muscles stronger or maintaining the strength within them. Your flexibility. So this involves like different body structures. So muscles, tendons, ligaments, kind of fascia, like the joint itself. Also will help with your coordination. And it can help with balance as well, kind of maintaining your balance and also improving it. So this would particularly be in standing and walking. It will also help increase your energy levels. So as your fitness kind of improves, your energy levels will likely also improve. It can help maintain healthy blood sugar levels. Then, as I mentioned earlier, to do with getting your heart to be kind of function better. It will also help with your overall heart health. So like reducing your blood pressure or heart rate. It has also been shown to help with bone health. So increasing like your bone density and help maintain a healthy weight. It has been shown to help reduce systemic inflammation. And then, like I mentioned here, then some different conditions that it can help reduce as well, or even if the condition is present, to kind of improve the management of these conditions. So particular types of cancer, heart disease, diabetes, dementia, mood disorders. Okay, and then also we're just continuing, there are more. So cognitive function as well. It's also been shown to improve your cognitive function. So like your attention, kind of focus, clarity, improve your breathing pattern. Okay, so you will often become kind of more aware of your breathing and more comfortable with it. And then your sense of well-being, increasing body awareness. So this is more your ability and perception of your actual body, how it's moving and feeling different body parts move. So this can in turn help to have kind of better like body posture, and also this will kind of relate to your breathing as well. Decrease stress levels and improve sleep. So it has been now talked about that exercise can be seen as a drug. So again, it can be an interesting way of putting it, and it can help kind of resonate with some people or get them to see it as being really important, particularly if you're looking at exercise to help with a medical condition. And as a drug, it's it's holistic. So like you've seen all those benefits I've talked about, and how it's really part of kind of being as well as you can be at a given time. It's a very holistic drug or therapy. It's safe, so very rarely nasty side effects. Of course, you know, you do need to be mindful and to exercise at your own level, which I'll mention a little bit later. You can titrate easily, or when you talk about dosage of drugs, so you can dose easily. So you can exercise at your level, and on different days you can do different amounts depending on how you feel. And with medications, obviously this will be harder, but with exercise, this is very easily done. Okay, so as I said, it is a key component of overall wellness, so it should always be part of our life. So it's part of my life, and it's now more known, I suppose, and people talk about it. So even for children, of course, and as you age, it's also very important. But you can use exercise, like I suppose when I mentioned, as maybe looking at it like a drug or a therapy. You can look at it to target a specific symptom or a specific condition. So sometimes when we do this, we use the term rehabilitation, because we're trying to rehabilitate and kind of improve the body or a particular part of the body, and because it has been affected by something. So we try and get it as good as we can at a given time. So often the exercise is a bit more specific, but then once this is done, I would definitely emphasize seeing again exercise is just part of your life or physical activity. So again, that it's not just for a particular period of time or not just for an illness. So examples of when you're using it kind of specifically would be pulmonary rehabilitation, like rehabilitation after surgeries for like knee replacement or cardiac surgery, or if you've like poor balance, having falls, or a neurological condition. These are just some examples. So Now I'm just going to kind of look more at lung fibrosis and physical activity. So all the benefits I talked about earlier apply. So even when you have a particular medical condition, you want your body to function as best possible, and this will be kind of how you can deal as best you can with the medical condition. So remember, your key to your wellness, so that of your physical body, your mind, and sense of self. However, as I've mentioned, you can use it to target specific symptoms or kind of conditions. So in lung fibrosis, then, I suppose the first and thing that we probably I suppose the most important would be the cardiovascular kind of and respiratory. So trying to get your heart to be kind of as strong and as function as best possible, so that it can work efficiently. And then also your breathing muscles, so particularly like the diaphragm, but also there's accessory other muscles that help, which are up more around our neck area. So to get these muscles to be fit and to have kind of more endurance so that they can work for longer. This will in turn help with your chest wall flexibility, so like the rib cage. And then with this, you'll get an increase, hopefully, in energy, a reduction in fatigue. It can also help reduce fear and anxiety, particularly related to your breathing and to activity. Because often with lung fibrosis, it's reported that people kind of reduce their activity because of the shortness of breath. And then this can lead then to kind of, I suppose, becoming basically less fit and less able. And then once people then maybe do try to become active, that they have a lot of fear in relation to their breathing. Okay, so it can help improve your breathing pattern also, and then overall improve your sense of well-being. So scientific evidence then for exercise and lung fibrosis, there is evidence available. Now there isn't a huge amount of evidence, but this can be the case often, and sometimes we know something is good, and sometimes the evidence has to kind of come afterwards. But there was a kind of a large review in 2021. So this is what was called a Cochrane review, and it looks at the evidence that is there. And they often have a question and see kind of what is there and does it prove it. So they were looking to see if pulmonary rehabilitation was of benefit in lung fibrosis. And basically what they saw was that it is of benefit and it has very positive results. Then there are other clinical guidelines in relation to lung fibrosis, and they also mentioned the use of pulmonary rehabilitation. And Liam mentioned this earlier in his talk, I think to do with the American Thoracic Society. Okay. So what they looked at, so kind of the clinical measures will be, they're looking for improvements in exercise capacity. So like maybe your 6-minute walk test, looking at improvement in a reduction in shortness of breath, and then improvement in quality of life. So how then you can get this or do this exercise and physical activity is, again, like we talked about earlier, I think it should be the focus on physical activity. So you're looking at basically exercise and activity throughout the day. And both of these are very important. So what would be good if you could have a combination of aerobic, so kind of for your heart, lungs. So this is kind of like normally a whole body activity, like walking, cycling, stepping. Then some resistance. So that would be like kind of doing weights. Then something to involve maybe some flexibility as well. And then a focus or improvement in breathing or breathing techniques. The exercise or physical activity can be structured or unstructured. So an example of like structured exercise would be the ILFA exercise classes, or other exercise classes that you can attend, pulmonary rehabilitation program, obviously. And these, again, Liam mentioned those, and they have been traditionally in hospitals, but now are moving more out into the community. They're often for a period like of, I think, probably about 8 weeks. The ILFA ones, I'm not trying to promote them, well, I am promoting them. They are actually like every week, and it's twice a week. So it's not just for a period of 8 weeks. So this is, again, really good because it has the bring an exercise into your life, and it's not just for a specific period. The pulmonary rehabilitation is very good because it can really improve your physical fitness, particularly if you haven't been active for a period of time, and there's a lot of assistance and supervision and advice as well. Then other activities like walking, cycling, dancing, yoga, golf, like other sports, like I'm not going to go through all of them obviously, weight training, swimming, tai chi, also like an exercise program that you could do at home. So this would be slightly more structured, and that could be provided by a physiotherapist or a fitness instructor. So how much? So this is something obviously that does come up for everyone, whether you have a medical condition like lung fibrosis, or even if you don't, often people, they're not really sure really how much they should do. So first of all, just to mention the intensity. So this is kind of more to do with lung fibrosis. Like some people would exercise to quite like an intense level, but with lung fibrosis, the advice and even the research is saying to exercise at a level of what we call moderate. So where you would be able to speak as well, so that you do feel your breathing is coming up, but that you would also be able to speak. Then in relation to how much, there are like some of the kind of health bodies like the WHO and in America, the CDC. So what a lot of these organizations are talking about is like approximately 150 minutes of moderate intensity exercise per week. They're also now saying ideally to include some muscle strengthening in this as well. But as for any medical condition or at a given time in your life, this may not be possible, but it's good to have a guide and to kind of know what is being advised. If you haven't been exercising or you're worried about like a change or a new symptom, my advice would be to speak to someone in your medical team. So to a nurse, physiotherapist, or your GP or your physician. So I guess then my, like I suppose take home message, or like what I really would hope is that you would be, I suppose, see exercise like not just as a chore, but something that really it is part of your life. And so it's a key to your physical and mental health in all stages of your life. So whether you have a medical condition or not, it's going to be one of those things that will help you to be as well as you can be. Okay. And yeah, thank you very much. And if there's any questions, I'm going to see if I can stop sharing.
I'll stop sharing there for you.
Yeah. And maybe I can get my video. Nope. Sorry, I don't know why I have disappeared, but I'm here.
You are here, and we were able to follow you.
Yeah, it's very strange. Yeah.
I think you're off the hook, Eimear. There's no questions come in, which means that it was clear and concise. And
if anyone has any later, just send them in, and I can keep an eye also. So.
We will do, of course, Eimear. Thank you for that. I'm going to hand over to Eddie. I'm going to get him to unmute there. Yep, perfect.
Thanks, Justin. Thanks again, Eimear. Very interesting. We just have to get up and do it from now on. Welcome back, everybody. And our next speaker is Carita Bramill, who is a researcher at Trinity College, Dublin. Carita's presentation is called Unmet Needs and Idiopathic Pulmonary Fibrosis. I'll hand over to you now, Carita.
As Eddie suggested, my talk today is on the unmet needs of patients living with a diagnosis of idiopathic pulmonary fibrosis. I just started my second year of my PhD program, and it's a 4-year program. Yay!
There we go.
Here we are. So I just started. I might just go back to the first slide if that's okay.
No problem. There we go.
Justin, will I need you to move those slides?
Yeah. If you just tell me next slide.
Perfect. Yeah. Okay. Thank you so much. So I just started in the second year of my PhD program, and it's a 4-year program. And I guess in the first year, it was really a lot of reading and a lot of getting through ethics in the various different hospitals in order for me to conduct my study. So a lot of that is now completed. And I suppose I'm hoping that I've reached the top of the very first mountain, and I'm back down in the valley and anticipating climbing the next mountain, as is the PhD. I'm lucky at this point that this year the Irish Research Council have awarded my study some funding, which as a researcher is essential in order to be able to conduct your research. This little squiggly thing, this box on the left-hand bottom side of the screen, is called a QR code. And I'm going to just let people know what that is, because I have to be honest, I wasn't really sure how to use QR codes myself, and then found myself in the unenviable position of having to create one and then let other people know how they work. But I now feel I'm competent in relation to QR codes. So this QR code, this little box on the left-hand screen, is actually a link to my study in order for patients to be able to complete the study or to find out some information about the study. And it's a simple case of opening the camera function on your phone, holding the camera as if you're taking a picture up to the QR code. And after a second or so, you will see a link pop up on your screen, and you simply click it and it brings you through to information about the study. Now, just because you click into it doesn't mean that you have to participate in the study. It just means it's bringing you into giving you some information. So I may return to that slide at the end to give people an opportunity to hold their cameras up to it if they would like to get information. So we might just move to the next slide. So as has been so eloquently discussed today, and patients, I'm sure who are attending here, have a good understanding of what IPF is, but I might just mention that this is a chronic, progressive and irreversible interstitial lung disease. IPF results in increasing loss of lung function and impaired quality of life. And as we heard earlier on, some of the symptoms that we tend to see patients present with into clinic would be breathlessness and cough, and they would be quite typical of seeing patients in the clinic initially with these symptoms. When we think about needs and unmet needs, we have to think about, I suppose, the burden of disease. And I like to look at this through, I suppose, a systemic lens. It moves beyond just the patient, but also onto those living with the patient, families, carers, and indeed the healthcare system. And we can see that the burden can be reflected in acute hospitalizations and high symptom burden for patients. We'll just move on to the next slide. So I guess in terms of numbers, and that's what epidemiology is all about. It's all about providing the backdrop or the landscape of who exactly has this condition, how many patients are there, how many patients get diagnosed every year with this condition. And I guess as a researcher and someone who's specifically researching unmet needs, I truly believe that understanding the epidemiology of the condition is a fundamental basic right that we should have in this country as regards understanding how many people have the condition. Now, we're basing a lot of our information on estimates. So we believe that there are about 1,000 plus patients with the condition in this country at this time. We believe, again, based on estimates, that around 400 new cases are diagnosed annually. We have a national ILD registry that was set up in 2016, but unfortunately remains unfunded. So I guess it doesn't contain as comprehensive information as we would like. IPF is typically more common in males, and the most cases are presenting in those over 60 years of age. And I guess then when we move down to international figures, what I will say to you is, from my reading of the literature, is that it's saying in the journal articles that the incidence or the amount of people diagnosed with this condition is increasing every year. And there are a number of reasons why they attribute this. One is increasing awareness. Secondly is an aging population. And thirdly are improved diagnostics. Okay. So I guess my study or my PhD proposal, when I initially thought about doing this research, was to look at and investigate the unmet needs and quality of life outcomes of patients living with a diagnosis of idiopathic pulmonary fibrosis. It's broken down into a number of objectives, but I guess the two key objectives from my study are to establish the unmet needs and quality of life of patients living with a diagnosis of IPF, from not only the perspective of patients, but also further evaluated by the healthcare professionals caring for patients. And then my objective number 2 is to inform the continuing development of services and healthcare delivery of patients in Ireland living with a diagnosis of IPF. So I guess when we conceptualize or we come up with a piece of research and we consider, our motivation for doing the research, or why is this research needed in the first place, we have to establish, I guess, the landscape of IPF in Ireland and consider why would people want to know about this research? Why would they want to read about it? So I guess one of the fundamental needs of patients living with a diagnosis of IPF is that we welcome further research in order to develop new therapeutics. We know that in 2011, that the two antifibrotics that have been so well spoken about today as regards Lindsay's talk in relation to some of the pharmacological therapeutics that are available in the form of nintedanib and pirfenidone. But of course, we would welcome new therapeutics for patients. We would welcome new medicines that could be offered to patients, particularly for those patients where those antifibrotic medicines simply do not suit them. And then I mentioned that in 2016, we set up an ILD registry in conjunction with the Irish Thoracic Society. But unfortunately, that still remains unfunded. So we can only provide estimates at this stage as to how many people actually have this condition in this country and how many people annually are diagnosed with it. So that we would like to see that change, and we would like to see a funded ILD registry in this country. At this moment, we have no dedicated clinical care pathway for patients with a diagnosis of IPF. And of course, there are marked differences between IPF and other respiratory conditions. We're also looking at a population who may experience other comorbidities. And we heard earlier on about some of the other conditions patients may also be experiencing, such as gastroesophageal reflux disease, such as cardiovascular conditions. So these are all other considerations and also needs that patients have that go across not only respiratory conditions, but also into other disciplines. This requires multiple layers of support, including shared care across the disciplines. And then we consider the symptom management. So we've spoken about some of the cough and the breathlessness that patients may experience. But what about the symptoms associated with some of the medicines that we offer to patients? So we've heard already that with the antifibrotic medicines, that they also carry some symptoms that patients may experience. So how do we best support patients in consideration of the symptoms they may be experiencing? And then again, when we look beyond the individual and we look at the impact of a diagnosis on not only them, but also the people in their families, the carers, and also the healthcare system. So the other aspect, not only when I look at the needs, but then I suppose hand in hand with that, I'm also looking at the health-related quality of life. And that refers to a person's satisfaction with aspects of life that may be affected by health. But it goes beyond this, and it looks at aspects of life such as freedom, quality of environment, and one's financial situation. Effectively, all aspects of life can become health-related. And I guess I created this little wheel here, this little diagram, to show the complex interplay between symptoms, perceptions, and reactions that may influence a person's health-related quality of life. So when we consider the journey of a patient with a diagnosis of IPF, we consider some of the symptoms that may impact their health-related quality of life. So we consider patients who may be experiencing cough. We consider the symptom of breathlessness, fatigue, emotional and psychological well-being. We heard from Eimear in relation to physical activity. But what of the patient, I guess, who finds that they're not able to be as physically active as they once were, and how best do we support them in relation to physical conditioning? And then I guess when there is a diagnosis of any kind, but in particular IPF, we consider one's independence and self-care, and we wonder about, I guess, our changing roles in the systems that we're part of, such as our family, our workplace. So on the left-hand side, I've kind of expanded on this health-related quality of life considerations. And I've moved into collecting information that I'm learning from the literature and that I'm learning from my interactions with patients in the clinical setting when I'm collecting information for my study. And I'm looking at some aspects that patients report to me that impact their health-related quality of life. So I consider the symptoms associated with some of the treatments that patients may be on and how patients are managing those. I consider things as simple or as practical as the burden of disease on frequent outpatient visits. So how is that for patients having to attend the hospital? You know, even something as simple as, you know, having to organise where will I park, how will I get to the hospital, what's the cost of parking going to be, who is going to take me to the hospital if I need someone to come with me. And then the interpersonal impact on the wider circle, including family, friends and work. The impact on finance. And I think this is something that sometimes gets missed when we consider health-related quality of life, because sometimes we focus on the physical and psychological symptoms. But actually, in a paper by Van Manen in 2017 and colleagues, they talked about that health-related quality of life transcends simply the physical and psychological and moves into areas such as the financial impact on patients and families. So for patients who are experiencing this condition, are there impacts around, I suppose, devices or aspects of their health that they've had to self-fund? And what can that do, I suppose, to a person as regards bringing maybe levels of worry or concern in relation to that? And then access to the multidisciplinary team. So we've spoken so much about the multidisciplinary team members that can be really helpful to patients. But I wonder about the access that patients across the country have to clinical nurse specialists, advanced nurse practitioners, physiotherapists, pulmonary rehabilitation, because I wonder, is it equal at all centres? And that's what I want to find out. What's happening nationally from a geographical perspective? Is the care similar as respect access to some of these multidisciplinary team members that can support patients? And then we consider the information requirements. So do patients feel that they have adequate information? Do they feel that they have enough information? Would they like more information? And then aspects of isolation. We know that during the COVID-19 pandemic, many of our patients cocooned, had to, I suppose, take on disproportionate level of burden in relation to the COVID-19 pandemic, in relation to continuing social interactions outside the home. So did that lead to levels of isolation for our patients? And then, as I've mentioned, the comorbidities, so the other conditions that people are experiencing on top of having a condition of IPF. And then we look to the right-hand side of the screen and we think about things like education. So how can we serve our patients best? What way do patients want to receive the information? Is it through events like this, run through the Irish Lung Fibrosis Association? Is it in the written format? So do patients want to receive written information packs? Would they prefer conversational education, where someone sits with them and talks to them about the condition? Would they prefer information given to them in small bite-sized chunks at each visit, or would they prefer a large quantity of information at the time of diagnosis? And I guess these are all the questions that I'm trying to answer through my research. And then we think of self-management. So how can we best serve our patients and support them so that they can self-manage their condition? We look to support groups. Is this something that will be helpful for patients, including patient advocacy groups? And then pulmonary rehabilitation. So are patients being informed about pulmonary rehabilitation? Is it something that they have access to at their particular centre? And then we think about, I guess, something like one area that I'm looking at is a thing called the social ecological model. And that, I suppose, brings into play the complex interplay between the person, the organisation or the hospital setting that they're attending, and indeed then policies. And one policy that we know in relation to Sláinte care, which is, I suppose, a move to moving some of the care that we offer to patients into community settings. So how is that for patients? You know, is that something that works for patients? Have patients been able to engage in perhaps pulmonary rehabilitation, physiotherapy visits, nurse-led clinic visits in the community? And what's their evaluation of that setting? And then looking at other supports that patients let me know about that might be helpful. So I'm thinking of some of the centres around the country where patients have large travel requirements. So they don't simply live within 20 kilometres of the hospital setting, but they live far and wide beyond that. So what supports can we offer there? Not all patients have someone available to take them to the hospital. And then we move into palliative care. And I think there's certainly a move in the literature about moving beyond simply seeing palliative care as end-of-life care, and instead viewing palliative care as an additional support in relation to symptom management for patients. And so this is something we as healthcare professionals see as really, really helpful in order to support the work that we do. and something that I want to include in my conversations with patients around their expectations about what palliative care might mean for them. And then, as I said, I put access to MDT on both sides because I think it's really, really important to wonder about the access needs that patients have in relation to the various team members. Okay. So when I was considering my work and my study, and I had to consider, well, what healthcare needs am I actually talking about? And this was at the very beginning of the study when I was devising some of the patient report outcome measures, which are my questionnaires. And so I turned to the work of Finula and colleagues in 2016. They came up with the European IPF Patient Charter. Now, we know since then that we've had other patient charters, including the Irish Lung Fibrosis Association Patient Charter. But I've used this as a kind of a baseline or a framework to frame my study around. And they talked about some of the needs that they identified were really, really important for patients. They spoke about early and accurate diagnosis. They talked about equal access to care, including medication and transplantation, irrespective of age. They talked about a holistic approach to standardized IPF management. They spoke about better access to palliative care and end-of-life care. And they spoke about comprehensive and high-quality information about IPF. And then I decided to move beyond the IPF Charter and to consider some contextual information. So what's different about Ireland? What happens here that may be slightly nuanced in comparison to our European neighbours? And so I looked at something like the COVID-19 pandemic and how our response to the COVID-19 pandemic was in relation to the way that we care for patients. I also looked at the Sláinte Care programme and that idea of moving some of the care that we offer to patients into community settings. I also looked at the idea of home monitoring. So things like looking at home spirometry for patients in the community and other aspects of patients' care that can be performed in the home. And then, as I said, the geographic spread. So what's happening around the country at the various different hospital sites in relation to the support that's available to patients at each of those hospital settings. And then I looked at areas around hybrid models of care. And of course, we saw an explosion of this during the COVID-19 pandemic. And that is in relation to, I guess, the face-to-face clinic and the virtual clinic. So what is it the patients want? Do they want a combination of both? Or would they rather just be seen in clinic in a face-to-face model? So these, again, are some of the questions that I'm trying to answer as I move through this research project, okay? So what exactly does my study include? So there are 3 key phases to the study. So phase 1 is almost completed and should be closed out by December of this year. And that included a quantitative questionnaire effectively for healthcare practitioners. So I wanted to find out from healthcare practitioners their evaluation of what they felt the needs of patients were. Phase 2 of the study then is the largest phase of this study, and that is the questionnaire that's going to be handed out to patients who have a diagnosis of IPF. And finally, in phase 3, this will be what we call a nested sample of participants. So that is participants who have been specifically chosen from phase 2 of the study to participate in phase 3. And that is once patients have obviously given consent to be considered for phase 3 of the study. And this will provide some, I guess, some of the in-depth and rich experiences of patients. And it will also allow me opportunities to follow up on some of the information that comes to light from those questionnaires in phase 2. As I said, phase 1 should be completed by December 22, and phase 2 and phase 3 should be completed by September 23, with a contingency to push it out to December 23. So hopefully all data will be in at that point. Okay, next page. Okay, so the hospitals that are included in this study at this point are the Mater Hospital, the Cork University Hospital, Galway University Hospital, St. James's Hospital and Connolly Hospital. So I have ethical approval to attend all of these clinics, which I've been doing since March of this year and will continue to do until September 23. So if you are a patient attending any of these hospital settings and you would like to talk to me, or you feel that this is something that you would be interested in, please do speak to your healthcare provider at each of these settings, as they will be aware of the study and can certainly signpost you to me, okay? And so one of my final slides here now is just in relation to the patient and public involvement. And I think this is something that's becoming essential and a really, really important aspect of our research, that we don't as researchers sit in a room and conceptualize research without actually involving the people that it impacts, and that is the patients. So earlier on this year, I worked with ILFA to establish this PPI group, which I'm just thrilled about. We've had our first meeting, which was absolutely wonderful, and that included, I guess, researchers, members from ILFA, and most importantly, patients. I have sent out what's called a scope and review protocol, or effectively a map for my literature review, a kind of a guideline document to patients and other members of the patient public involvement group to review and to give their feedback. And I guess throughout my research, I want to include and incorporate the patient voice throughout all aspects of my research, as I think it's essential. Okay. Okay, so final slide. So if you like the sound of what I've spoken about today, if you feel like you would be interested in getting more information, if this is something you feel that you could assist me with, in order to, I suppose, provide the correct statistical analysis for my study, I do need a sample of around 278 patients with the diagnosis of IPF. So if you are a patient who has been diagnosed with the condition IPF, you are being treated in a hospital in Ireland and you're over 18 years of age, and you would like to get information or indeed participate in the study, my email is Bramill. It just has the one L in my email, c@tcd.ie. And yesterday, I'm thrilled to say I purchased a study phone. So I now have a phone number for the study. It is 089 234 9473. Justin, can we just go back to the first slide, if you wouldn't mind, for a second?
Yep, absolutely.
People just a second.
Sorry, I'll go to the last one and then start it again.
Thank you so much. Thank you. So I just want people to just have that opportunity to look at that QR code. So as I said, I'll just call out the phone number again. It's 089 2349 473. And as I said, my email is bramhillc@tcd.ie. So that's BRAMHILC@tcd.ie. And then this is the QR code. So you just turn on the camera function on your phone, you hold it to the QR code. And after a second or two, the study should come up on the phone. So thank you so much. And indeed, thank you to the patients and the healthcare professionals that I meet at the clinics who have been absolutely amazing in supporting my research. Thank you.
I'm just going to leave that QR code up for another 30 seconds or so. I see there is one question there that you might want to answer privately there from an anonymous attendee. Probably about your studies and maybe getting involved as well, if you can see the QR.
I can see it, and actually I'll say, look, I have approached many hospitals, and I guess the hospitals that came back to me are the ones that have been included in the study. So if you are a patient, you are not in one of the listed hospitals that I mentioned, you can still participate. So I have ethical approval from the Faculty of Health Sciences in Trinity College Dublin to recruit participants who are not attending those hospitals. So you can get involved by phoning me or by emailing me, even if you're not attending those hospitals, because I have ethical approval for that now too.
That is super. Thank you so much for that, Carita. I'm going to hand over to Eddie. I know people have been answering questions on our panelists have been answering questions throughout the whole presentation, but we're conscious of time, so I'll hand back to Eddie.
Okay, thank you, Carita. A very detailed and good presentation. Thank you so much. Our fifth speaker today is Danny Sheahan. Danny is a researcher at Invisio Limited. ILFA has worked with Danny for a few years to develop, deliver, and analyze several of our research surveys. Earlier this year, we asked patients and caregivers to complete an online survey on the physical, emotional, and financial impact of lung fibrosis. I'm delighted to welcome Danny to talk about the results of this important survey. So Danny, I'll hand over to you now. Thank you.
Thanks very much, Eddie, and thanks very much to ILFA for the opportunity to share these results with you today. I'll just bring up my slides here. That's okay. Yep.
Yeah, that's perfect.
Great stuff. Yeah. So I'll quickly go through the highlights of the results of this survey that was conducted in July of this year. So it was an online survey of ILFA patients and caregivers conducted over a couple of weeks in July. Today, we're looking at 155 responses. So that consisted of 102 patients, 32 of whom were on oxygen. And we also included 53 caregivers or family members in the survey. We had a very good representative response around the country. So 37 from Dublin and a good spread throughout the rest of the country. And just thanks very much to everybody who took part in the study. As Carita mentioned there, it's great to get a good number of responses in, and very important, and kind of giving you a robust number. So we were looking at the impacts of IPF across various levels. So for patients, we looked at the impacts on daily life and activities. The top impact for patients in terms of activities and day-to-day living, 94% reported fatigue or tiredness. Shortness of breath was reported by 81% of our respondents. Disturbed sleep by 80%, and coughing by 74%. So these were the top four, all experienced by the majority of respondents. We had other impacts reported, all by less than 50% of respondents, but significant nonetheless. Reflux, difficulty talking on the phone, problems eating or drinking, and stress incontinence included there. For caregivers or family members, we had fatigue and tiredness and disturbed sleep were in common among the top four impacts in common with patients. Caregivers also a majority reporting impact on socializing and impact on general health. We also noted significant impacts among caregivers on hobbies and the ability to pursue hobbies and their own exercise. So then in terms of patients' activities, 71% of patients reported experiencing problems with climbing the stairs. 71% with exercising. 67% experiencing problems in carrying out household jobs. And 65% with hobbies and leisure activities. Other impacts on daily living were spending time with family and friends would have been reduced, showering or taking a bath, and getting dressed. Again, but by less than 50% in all of those cases. We also looked at the emotional aspects of IPF. And among patients, concerns for family members were the most common reported. Fear of getting an infection at 80%, and obviously, I suppose with the presence of COVID, that's increased, and we did conduct a previous survey around the impacts of COVID as well. Anxiety experienced by 65%, low mood by 64% of patients, and again among caregivers or family members. Again, similarly, the concerns for family were the top emotional impact. Guilt or worry was also high among caregivers or families. So the question is, am I doing enough for the person I'm looking after? So they kind of worry about that. Loneliness, anger, and frustration also featured among caregivers and family members. And we had the financial impacts of IPF then. So patients, okay, so patients worrying about heating costs, that was the highest that we recorded. Electricity costs at 61%. day-to-day costs at 59% and your own income. And I suppose it's important to just to bear in mind this was conducted in July. So I reckon, you know, if we were to run this again, maybe that electricity cost would be maybe higher on the radar as it is for everybody, I think, at this stage. And indeed, electricity costs were a worry for 68% of our oxygen users back in July. And then caregivers and family members, similar concerns in terms of the financial impacts. The highest one here, financial impact on the spouse or family, followed by electricity, day-to-day, and heating costs as well. Just continuing on the financial impacts, we did ask about electricity bills. So again, this was in July. The average bill amount that we recorded was €241. But again, people get different different billing cycles, so you could be on monthly or 2 monthly bills. So when we broke it out, we asked about that as well. We broke that out. It works out at an average of €134 per month. And again, with the rising cost of electricity, that's only going to be higher right now. And I suppose that's very topical, and everybody is acutely aware of that at this stage. Impact on working life, 42% of patients had to stop working or retire because of the effects of lung fibrosis. So that, I suppose, combined with the financial concerns, you know, it will only add to that for those impacted in this way. In terms of supports and help then, 53% of patients had a medical card. And that rose to 72% among those on oxygen. 74% had help with daily activities from family or friends. 26% reported not having a family member or friend helping them with their daily activities. 6% had home help coming in. 15% had their home adapted. So they're just brief highlights there. I want to say thanks very much again to everybody who took part in the survey. It's really, really important to get good, robust numbers on these surveys so we can understand the day-to-day experience of ILFA patients, ILFA members, and caregivers and family members as well. So thank you very much. If there's any questions, I'll be happy to answer them.
Thanks for that, Danny. I think we're clear on questions at the moment, which is great. If any come in, I'll let you know. I'm just going to hand over now to Eddie to introduce our last speaker and patient story. Eddie.
Yeah. First of all, I'd like to thank Danny for the results of the survey there. Very detailed. And thanks again for your presentation. It was really most informing. And to everyone who responded to the survey, the data generated from the research surveys are so valuable to ILFA, and a number of studies have been written up and published in some medical journals. So thanks again to everybody who participated, and thank you again to Danny. Our next speaker is Finula Rice from Cork. We are delighted to have Finula share her story with us today. Over to you now, Finula.
Hello, everybody, and thank you. Well, my experience to date will not be that different to a lot of my ILFA friends, I suppose. I was diagnosed in 2019. I have systemic sclerosis, ILD, so that I know what's causing my pulmonary fibrosis. I was, I suppose, complaining for about 3 years prior to that. I had, since 2016, been going to my GP with a persistent cough. I have to say I didn't notice the breathlessness at that stage, although I was having difficulty keeping up with friends, but didn't make the connection. Was fit, walked every day. Anyway, I was treated for nasal drip and asthma, and it was only in 2019 on holidays again that I knew something radically was wrong. going up steps, walking up any incline at all. I assumed it was my heart, the pain, the breathlessness. So on my return, I went to see my rheumatologist, who was treating me for scleroderma, which I had been diagnosed with since 2002. So he immediately sent me for a high-resolution CT scan, which showed up the pulmonary fibrosis. So I got a letter then informing me I had it on the day I got back from a holiday, and I didn't know what it was. So I Googled it. So I got a fright, no more than anybody else would. And just my world kind of fell apart straight away. And I assumed the end was nigh. So I was referred onwards then to a respiratory physician who organised, I had a bronchoscopy and a pulmonary function test and x-ray. And I had been on methotrexate for years for the scleroderma, and it was thought that perhaps that could have been in the mix, that apparently there's a train of thought out there that perhaps methotrexate can contribute to fibrosis. So I was changed from that to Celcept. So I continued under the care of my rheumatologist and the respiratory physician. So I'm just getting the PFTs every 6 months, visiting the respiratory physician. At no stage was I told about pulmonary rehab, respiratory nurses, support groups. I was just told to exercise. And I was a year into the diagnosis then during COVID, and I treated myself to the Irish Times being delivered, and I saw on the back of the page an ad for ILFA advertising an upcoming event, and I got onto them and everything changed for me for the better after that. I was given information packs. I was invited to online exercise classes, yoga classes, sing for pulmonary health, and the information. They have been a huge support to me, for which I am very grateful. And as I said before, it's not just a practical help and advice that they are giving. There's a huge psychological boost to being a member of ILFA as well, because it was the first time I got to speak to other people who had pulmonary fibrosis, who had similar experiences. And for those who are further down the line, they had worse experiences than I have had to date. So August the 31st, I was finally referred to the specialist centre here in CUH. So I thought I had it made, but I came away feeling a bit deflated, to be quite honest. I was told I'm not guaranteed a pulmonary function test before each consultation, and I don't see the point in a consultation without a PFT. Funding, it was indicated to me that funding was quite an issue. I asked about a respiratory nurse, and anyway, long story short, I accessed a respiratory nurse through the good offices of a friend of mine, also in ILFA, who very kindly rang me and gave me the name of the respiratory nurse, who was very helpful. I couldn't wait to get in touch with them because I believe that they are an invaluable resource. She explained to me that when I'm put on the OFEV in January, that she will come into play in a big way then, giving me advice, etc. I have been put on a waiting list for a face-to-face pulmonary function rehabilitation class. I've never had the 6-minute walk, and it's a kind of still hopeful. I must admit, especially having listened to this morning's presentation on the drugs, that I'm quite nervous of going on the OFEV. I'm worried about the side effects. I would confess to a lot of anxiety about that, because there has to be some kind of quality of life as well. And it seems to me that if you're unlucky enough to have the adverse effects, that the fun would go out of life to some extent or another. Pulmonary fibrosis has shrunk my world. I used to be in a choir, which I enjoyed. We got to go all over the place. COVID, of course, put paid to a lot of that. But even though singing is good for your lungs, I'm afraid to go back to choir because it's a large group. There are 40 people. Perhaps I'm overreacting. I know that there are some people in ILFA who are in choirs and who have gone back, but I'm just so afraid of picking up any kind of an infection at all, that I am living quite an isolated life at the moment. I live alone. My family are in Portlaoise, and they consist of my 89-year-old dad and my 60-year-old brother. So I'm listening to people who have carers and the problems carers have as well, but I'm thinking how lucky they are to have somebody to care for them down the line. I'm not on oxygen yet, and I pity my ILFA friends, as I would say, who are on oxygen again because of not just the inconvenience, but the cost of it coming into the winter. So other than that, I don't know what the future holds. I'm hoping that perhaps funding will come down eventually for pulmonary fibrosis patients. I know it's not included in the National Clinical Care Respiratory Program, which is a bizarre situation to me. I would hope when service plans are being drawn up that pulmonary fibrosis would form a great part of a service plan to provide services for people in need for the following year. As in my case, the untimely diagnosis delayed matters. I believe that some GPs still wouldn't be too au fait with the ins and outs of pulmonary fibrosis, and that many people are not diagnosed on time, which is time wasted, basically. However, all of that doom and gloom, I'm still positive and hopeful for the future. I'm hoping they'll find a cure, maybe not in time for me, but down the line. I'm hoping they'll come up with therapies that will help and that will be well tolerated. And I'm just grateful for ILFA and all of my ILFA friends that I have made as well. They have been an enormous support to me, and I can't thank them enough. And I hope that's enough.
Thank you for that, Finula. I'm just going to unmute Eddie. It's great to hear patient stories.
Absolutely. Thank you so much, Finula, for being Finula and being so honest. It's really, it tugs at the heartstrings, let's put it that way. You have been so honest and so inspirational. So just keep looking on the bright side of life. That's all I can say. And I wish you the very best.
Thank you.
Yeah. Okay, so now we come to the closing. My sincere thanks to all speakers for their excellent presentations. As always, we are grateful to everyone on the panel for their time, their expertise, and their kindness. I think that was a fantastic series of talks this morning. I'm also very grateful to Gemma O'Dowd and to Anne Griffin for all their hard work and dedication behind the scenes. We're enormously grateful to Justin for his expertise of managing technology to deliver this event online. It's really brilliant. Thanks to our amazing fundraisers who work hard to ensure that ILFA can continue our work. ILFA depends on fundraising and donations, and all support is greatly appreciated. If you would like to fundraise for ILFA, please get in touch. And if you or a family member is a member of a club or a society or a company, please consider ILFA as a potential charity partner. We would welcome the opportunity with open arms. Thank you to the ILFA board for their time and dedication to run the charity. If you have skills that would be useful to the ILFA board, particularly in finance and governance and legal matters, and have time to volunteer to help ILFA achieve our mission, please get in touch. ILFA Christmas cards are now available to order, and we would appreciate your support to help raise funds and awareness. We hope you've enjoyed this Patient Information Day and will join us again, all going well, in 2023. So if I may say, thank you all once again for joining us today. I wish you all a lovely weekend. I'm asking you all to stay safe, and let me be the first to say Happy Christmas to you all and a very prosperous New Year. So, slán.